So the the topic is what to do with the bicuspid valve when the aorta is dilated, which of course is the main focus. Just briefly, aortopathy is present. It's roughly 50% of the patients that at one point in their lifetime will develop an aneurysm. And there is a frequent occurrence of valve disease, whether it's regurgitation or stenosis, and whether it's aneurysm involving the root or concomitant valve disease, some treatment of the valve will be necessary. And this is where repair is a possibility. Repair with a possible low incidence of valve-related complications, maybe also better survival. Let me go into the historical treatment. Valve replacement has been the standard of care in the last 50, almost 60 years. And for many decades, we believed it was a curative treatment. The VA trial, and here this graph is taken from the publication of the late results, has shown us a slightly different picture. After 10 years, 50 to 60%, whether it's a biologic or a mechanical valve replacement, have developed at least one relevant valve-related complication. The VA trial may be criticized because first-generation valves were involved. And now, and this is a discussion that we know from interventional treatment, all implants are much better. So on the right-hand side, you see a long-term, a 30-year follow-up study on patients who had a mechanical valve replacement with the St. Jude valve, which is still standard of care. You see there is a similar incidence of valve-related complications, and there is also valve-related mortality at a range of close to 1% per year. It's not the only study that shows valve replacement has a problem. In this Swedish study, the patients compared predicted and observed mortality following aortic valve replacement. They found excess mortality and stratifying the patients according to age, and patients with a bicuspid valves are the ones that usually come for surgery at a younger age group. There was clearly documented excess mortality. This we can do better with a repair if we do it right. This is on the left side, an earlier publication which showed that at 10 years, freedom from valve-related complications is roughly 85%, with repair failure being the most frequent such complication. On the right side, just for comparison, the graph from the VA trial. Well, when the aorta is dilated is the topic. And we need to keep in mind that there are different types of dilatation. There is the tubular type, there is the root type, and there is a combined type. Do we have to be aggressive for all? This study published by the Mayo Clinic looked at the stability of the aortic root following replacement of the tubular aorta for aneurysm. And at least within a 10-year interval, the root dimensions remained stable. This led Dr. Sund to simply conclude that bicuspid aortic valve aortopathy is not cancer, and I happen to agree with him. So if we treat the dilated aorta, we simply have to carefully look at the pattern of dilatation and treat the dilated segments. So either the tubular aorta or tubular aorta, including the root. And this is what we can combine with a repair. In addition, we also need to keep in mind that not only the aortopathy comes in a variability of phenotypes, but also the valves vary. And in one of the important variabilities is the different patterns in symmetry. Roughly 40 to 50% of the patients have near symmetric bicuspid orientation of the two functional commissures. There are the asymmetric bicuspid valves and the very asymmetric that resemble a tricuspid valve. They usually come by with very limited, that is, partial fusion. To come back to repair, the history of repair is old. It's now more than 30 years ago that the Cleveland Clinic published the first early results on repair. The principle of repair in those times, and this was also the base in this study, was the assumption that prolapse of the fused cusp is the main problem, and this was corrected using the non-fused cusp as a reference. At the end of the operation, the cusp margins should be at equal height for valve competence, and then everything would be well. In order to, well, give surgeons additional advice, some opinion leaders proposed that the valve should look like praying hands. Praying hands, to me, even though I do believe in God, is not a very specific goal that we can use. We actually, and this was 20 years ago, stumbled across a pattern of repair failure that made us think. We found several bicuspid valves after aortic replacement that looked like this and that failed within the first couple of years and needed reoperation. This made me look into what we knew about aortic valve form. Swanson and Clark, for me, was not very helpful. So I assumed that maybe the height difference between the annular plane and the free margins, which I called effective height, could be used as a configuration parameter. This is something that we can determine by echocardiography. This is something that we can also measure in the operation if we have a caliper that simply gives us the height difference. And we found that this was indeed a helpful parameter, with normal dimensions being in the range of 9 to 10 millimeters. Of course, an aortic valve also needs sufficient cusp tissue in order to function. In the absence of good literature data, we went ahead and prospectively studied more than 600 patients, including many bicuspid patients, looking at the geometric height, that is the tissue height from the nadir to the free margin in stretch version. And for the bicuspid, because of the variability of the fused cusps, we primarily focused on the non-fused cusp. As you can see in this graph, most non-fused cusp had a tissue height and a geometric height of 20 millimeters or more, and the mean was 24 millimeters. Further studies, including computer simulation studies, showed that effective height and geometric height in normal conditions have a relatively close relationship. That is, effective height is roughly geometric height multiplied by 0.45, which corresponds to the data that we found. 20 millimeters would result in a normal effective height of 9 millimeters. In other terms, if we now take the complex form of the aortic valve with sinotubular junction and virtual basal ring determining the aortic dimensions, the effective height will be the parameter that gives us information on valve configuration. The difficulty now for aortic surgery is if we reduce aortic dimensions, the sinotubular junction, this will reduce intercommissural distance, reduce effective height, and thus induce prolapse. This, however, can be picked up by intraoperative measurement of effective height after restoration of root dimensions, and this procedure has effectively improved the competence and durability of the procedures. Let us look into a few details that we also need to keep in mind and results of the analysis of the first 300 bicuspid repairs that we did. As you can see here, effective height, also in this retrospective analysis, proved to be important. Root replacement, whether it's done as remodeling or reimplantation, markedly improves the stability. And there is something particular about non-root replacement repair procedures that need to be looked at in detail. One of the issues is that annular size, and bicuspid aortic valves usually come by with a large annulus, is a predictor of repair durability of failure, with marked annular dilatation increasing the probability of repair failure. Most interestingly, and this was unexpected to me, also commissural orientation was an important predictor of repair stability, with the asymmetric and in particular very asymmetric valves having the worst results. Different concepts for annular stabilization were developed. We followed the way to use suture annuloplasty to better accommodate the anatomic variability of the root, and with the addition of a suture annuloplasty, the probability of repair failure could be drastically reduced. The other question was what to do with the commissural orientation. Of course, we can do a root replacement, which gives us degrees of freedom to place the commissures in a new and ideally symmetric position. But this, to me, appeared overly aggressive in patients who do not have marked root dilatation. The hypothesis was that we used, if we simply eliminate part of the circumference on the fused sinus by plicating the tissue. As you see here, there is the fused sinus and you see the thickened tissue after plication. We will bring the commissures into a more symmetric position, and this should ideally improve durability. I was happy to see that indeed the creation of a more symmetric bicuspid valve improved repair durability. Not only that, the mobility of the fused cusp and systolic gradients were also significantly improved by creating a symmetric bicuspid valve. These findings led in more and more hands to a change in principle of repair. If the valve is symmetric or near symmetric, 160 degrees or more of commissural orientation, it is simply kept symmetric. The asymmetric bicuspid valve is made symmetric, and the only difficult substrate is the very asymmetric, the almost tricuspid-like aortic valve, which needs to be treated in an individualized fashion, and often concepts of tricuspid aortic valves should be applied. Using such repair approaches, actually the vast majority, in our hands roughly 90% of non-stenotic bicuspid valves can be repaired. And as you can see here, reasons for replacing a non-stenotic aortic valve were mainly extensive calcification, especially in the raphe, active endocarditis, or retraction. The results have improved over time. And in this analysis, with a large cohort of more than 1,000 patients and a mortality in the range of 1%, we could show that addressing these anatomical features improved survival. Well, they will not all live forever. More importantly, the durability of the repair procedure was markedly improved, and we now have more than 90%, somewhere in the range of 95% of the patients stable and with minimal valve-related complications at 10 years and beyond. The only problem that has remained is the need to insert material into the valve as part of cusp repair. Traditionally, we have used pericardial patches for this purpose, and these patches degenerate and lead to failure in an accelerated way. Let me summarize. Bicuspid aortic valves in the context of aortic dilatation can be repaired in reproducible fashion. The repair must address the morphology, and commissural orientation has shown to be an important feature. Geometric parameters aid in selecting an adequate substrate to make certain we do not try to repair a retracted valve, and adjusting the degree or amount of cusp repair. The good aspect is that repair results in minimal valve-related complications if durable, and the durability of bicuspid repair is good if there is adequate tissue, complete elimination of prolapse, and commissural orientation of 160 degrees or more. I thank you for your attention.